How much do you really know about pain? Though millions of Americans suffer from chronic pain, proper education around management and treatment is lacking. Dr. Tanya Palermo, a professor of anesthesia and pain medicine at the University of Washington School of Medicine, says that understanding why your body hurts is crucial to healing.
Pain is a complex topic because it's both a symptom and experience, but it also can turn into a chronic disease. So everyone essentially experiences pain at some point in their life. It's usually what we call acute pain, which is pain that's related to, everyday aches, pains, illnesses that we expect to resolve quickly. And there are different kind of physiological processes that are important for acute pain. When pain continues, though, to occur and persist, it really does transform in both there's brain and structural changes that can be seen in what is maintaining pain, but there's also a shift in lots of other behavioral, psychosocial processes that can also maintain pain.
Sound complicated? It is. Palermo also directs the Center for Child Health Behavior and Development at Seattle Children's Research Institute. She says that the common mistake made is treating chronic pain the same as acute or short-term flare-ups. Taking medicine to try and immediately fix the problem doesn't work when it comes to the complex processes that maintain those negative signals. However, some of these systems that exacerbate the issue are helpful processes that have just become dysfunctional. The endogenous pain-relieving systems are a good example of this.
Endogenous pain-relieving systems include neurotransmitters and peptides that are there's so many. It could be serotonergic. The endocannabinoid system, which is what cannabis binds with, is the most populous. There's dopamine, there's glutamate, there's acetylcholine, there's the endogenous opioidergic system, which is considered to be the primary pain-relieving system.
That's Fadil Sadan, director of the Pain Health and Mindfulness Laboratory at UC San Diego. He says a good example of seeing these systems in action is getting a minor injury. If you stub your toe, your body will release a bunch of natural opioids to reduce that pain.
It's a built-in system to help us feel less pain, which is why when we take opiates for acute pain, it can reduce pain because it binds with the opioidergic receptors that already exist in our body.
Notice that his keyword here is acute, because despite what you may have been told, opioids are not effective for chronic pain.
In fact, they make chronic pain worse. That's been shown over and over and over again. It is not a treatment for chronic pain. Does that mean there's not a time and a place for opiate administration for chronic pain? Of course not. That's not within my level of expertise. But the literature is pretty clear that opiate use is not helping chronic pain. Chronic pain is multifaceted. It's complex. Thus, the therapies needed to treat it also need to be multifaceted and multimodal.
Palermo agrees, believing that an ideal treatment team for chronic pain includes multiple health professionals, such as a physician, psychologist, and physical rehab therapist.
This is a long-term problem. It shouldn't be viewed as a symptom. And when you have complex chronic pain, the viewpoint of the care team needs to be that this is a chronic condition, and it should be educating patients about that, giving them some insight into, where might vulnerabilities come up later in life where symptoms might get worse. And so I think, again, that treatment team is so important to construct. At this time, there is the most evidence for psychological and behavioral therapies and for some physical rehabilitation therapies, much less evidence for medication or pharmacotherapy being helpful for this type of persistent chronic primary pain problems.
Zadan's 2024 paper published in PNAS Nexus aimed to see where meditation landed on this spectrum. Since it's believed that humans use our internal opioid system most commonly to regulate pain, the team set out to find out if mindfulness meditation could piggyback on this process to reduce pain.
We asked a very simple question based on all this literature for the last 50 years that says that endogenous opiate system is the main way we reduce pain. So we blocked the opiate system from working when people were meditating in response to pain. And we found that meditation still worked, even though we were blocking the opiate system from working. So that let us see something really cool and new, that meditation isn't using the system, it's something else.
But that wasn't the only surprise. Zidane's student at the time wondered if this effect differed by the participant's sex. At first, Zidane completely shut down the idea because the past few studies they had done hadn't shown anything to suggest sex-based differences. However, once they combined all of the data, they were able to see the more subtle themes occurring in their research.
What she did was she took all of my experiments where we blocked the opiate system from working during meditation, and we looked at males versus females. And sure enough, she was right. When we blocked the opiate system from working, meditation no longer works in males at reducing pain. It just blocks the effect completely. Well, more or less. Not completely, I guess. But then when you block the opiate system in females during meditation and pain evocation, the pain relief actually gets stronger. Like, they got better when we blocked the opiate system. So we saw a clear and large effect. Actually, it wasn't that subtle at all. We saw a pretty significantly large effect in differences in the way that males and females are reducing pain in the body.
So this long-held belief that all humans primarily use the opioid system to internally reduce pain may not be true for women.
This was the first study to show this difference between males and females in the context of any pain modulatory technique, distraction, placebo, hypnosis, prayer, whatever, in humans. This effect has been shown in rodents, like once or twice, but never in humans. So we were pretty I'm still blown away by these findings.
Because if this finding turns out to be true, it will significantly change how pain is treated in women. Currently, women are more likely than men to be prescribed opioids. But has that been the wrong approach this whole time?
For an extended period of time, we were prescribing opiates like candy. And it created basically the opiate epidemic in this country. And we know from the literature that those prescriptions were significantly higher for women than males. Those increased rates of prescriptions may be associated with the fact that women were taking more because the opiates weren't binding with their bodies, biologically speaking. If this does stick, it doesn't make any sense to give women opiates because it doesn't seem like their body is as responsive to the endogenous opiatergic system, which suggests that they're using something that's not endogenous opiatergic.
Zidane is quick to point out that this is the very beginning of this research. In order to even confirm this finding, the study has to be reproduced multiple times before moving into real research of this hypothesis. And though he's only able to speculate on very limited and unconfirmed information, Zidane's hunch is that the female body uses the cannabinoid system for pain relief.
Because that is the most populous system. We have the most receptors. Endocannabinoids are highly analgesic, highly pain relieving. And they're, in the context of candidates for pain relief, it's likely either going to be opiatergic or endocannabinoid. You could get some support from the serotonin system, from the dopamine system, but generally speaking, in the context of pain relief, it's those two.
But again, this is only the beginning. This finding could be found to be completely off base, or it could be the start of an entirely new understanding of how humans process pain. We'll only find out after years and years of further research.
This study is the first time that we've seen this in humans. There's definitely differences in the way that endogenous opiates work between males and females to reduce pain. This is during meditation. It may not come out during placebo. It may not be an effect during distraction, or other techniques. No idea. We just started. And this was a very surprising discovery. Like, we were not expecting this. In fact, I thought Michaela was wrong. And it ended up being, I think, our biggest discovery.
Zidane says the team is first going to look at if this effect is specific to meditation, and then research how men and women react differently to cannabis to test their theory that females will have a greater response. But while Zidane's team works on the future of pain research, Palermo is focused on educating the public on what we know now. She says that there's a big gap in how patients understand chronic pain, which can actually hinder treatment and healing. Join us next week as we discuss how this education is evolving to impact the most patients possible. You can find more information about Dr. Tanya Palermo, Fadl Sadan, and all of our guests on our website, radiohealthjournal.org. For more behind the scenes, follow Radio Health Journal on Facebook, Instagram, and X. Our writer-producer is Kristen Farah. Our executive producer is Amira Zaveri. I'm Elizabeth Westfield.